Hi everyone. This is the second part of the lecture for Lab 5. In the previous lecture, we talked about peripheral nerve injuries, their implications, as well as what we do to address or to work with people with these diagnoses. So in this particular lecture, we'll go through the rest of the labs and or the rest of the lecture for this particular lab, and we'll take a look at uh, uh, different implications or considerations for working with shoulder um, impairments, particularly neurological based shoulder impairments, different exercises, positionings. We look at postural assessments, assessment and management of spasticity. And of course, there will be hands-on portion when we meet in person for the lab. All right, we looked at this in previous slide or previous lecture, so I'm not going to go into them. Now, the shoulder. Um, the shoulder is it does have what's called a lattice degree of freedom. What that means is that the shoulder, because of the what the articulation looks like, right, is the head of the humerus into the glenoid fossa. Because of the that articulation being a little bit shallow, it allows for different movement in different planes, right? So shoulder flexion, shoulder extension, shoulder abduction, um, and internal external rotation. Now, shoulder movement is also coupled with scapular movement, right? So when the shoulder moves, the scapula is not fixed in space. The scapula moves along with it. And there is a particular rhythm for how much the scapula moves, for how much the shoulder moves. Now, of course, the arm is the elbow and the hand and the fingers are also involved, and so of course the elbow has movement in elbow flexion extension, definitely less in terms of its degree of freedom compared to the shoulder. Same thing with the wrist flexion extension, radial ulnar deviation, and then of course the fingers are flexion extension, adduction and abduction. Multiple planes of movement, but again, the shoulder has much more planes of movement compared to the the rest of the joints. All right, so in the case of people with an impairment of the upper extremity related to a neurological condition, stroke, traumatic brain injury, and such, when we mobilize the or when the arm moves, we understand, of course, that, as I said earlier, that the shoulder blade moves with it as well. It works in conjunction with the humerus and the clavicle and the rib cage. So that, the shoulder is not an isolated thing, right? The scapula is connected of course, to the head of the humerus. The scapula is also connected to uh, oh my gosh, the collarbone clavicle, and the clavicle is connected to the rib. So it's really a system of structures that are connected to each other. And so there is, a disruption in one part of it can essentially affect the movement in the other part. When we do passive range of motion, it's important to stabilize the scapula. Um, Again, when we do passive range of motion of people with neurological based um, arm impairment, right? Hemiparesis, hemiplegia, and all of that. You want to make sure that the scapula is stabilized. Um, of course, body mechanics is important. So when you do mobilize, be conscious of your body mechanics as well. These range of motion or passive range of motions, you can do it with the person sitting at the edge of the bed, where or the person is supine, lying down in the mat or in the bed, or a side laying where the scapula is easily accessible. Um, Now, when we do, so there's different type of range of motion assessments, right? There's the passive range of motion where the therapist is doing all the work. And then there's the active range of motion where you're trying to see how much the person is able to move the limb in different planes without assistance. Active assist range of motion would be when you are having the person move as much as possible, but of course, as a clinician, you are also you're helping the person achieve optimal movements. With passive range of motion, with any of these range of motions, really, as in order you can train family members on how to do these range of motions at home from a home exercise program standpoint. However, you have to make sure that they return demonstrate safety and appropriate. They return demonstrate ability to assist the person with these range of motion exercises within the clinic setting before you prescribe it as a home exercise program, right? Self range of motion is a range of motion exercise that oftentimes we have people do on themselves, right? There are different kind of techniques for these self range of motion exercises. And again, when you prescribe this exercise to a person at home, the patient has to demonstrate ability to do that safely, independently within the clinic setting. Never use a pulley for a hemiparetic shoulder. Now, pulleys have their benefit, right? Particularly for orthopedic-based injuries, frozen shoulder and things like that. They can have a place in within the therapy sessions or even at home for home exercise programs. But for hemiparetic shoulder pain, never use a pulley. All right, different type of range of motions that you can do. First, against gravity would be person sitting or standing with gravity. Be essentially in the way that gravity assists the movement. And then gravity eliminated are different ways in which that you could do range of motion assessment and exercises as well. When you document range of motion assessment, as much as possible, it is appropriate to do specific measurements. So using goniometers, right? As much as possible, the best thing to do is to assess using goniometers so that you have specific data. When you do range of motion assessment, make sure that, of course, person is not compensating. So, for instance, right, if you're doing shoulder flexion assessment, range of motion assessment, if you're so much focused on administering the goniometer that you don't notice what's happening at the top of the shoulder, a lot of times people compensate for deltoid weakness by engaging the upper trapezius muscle, or meaning that they shrug the shoulder to lift the arm up, right? And so that's really compensatory movement pattern. So if you're not very careful, you may assess the range of motion higher than what it actually could have been if that compensatory movement was not applied. All right, manual muscle testing, very much important to document how much strength a person has, right? And this is, you're going to isolate specific planes of movement to assess a person's strength in moving in that plane. For instance, shoulder flexion, of course, shoulder abduction, internal, external rotation. So you're going to specifically assess the person's strength in those planes, in any plane that is normal that is appropriate to assess, I should say. Manual muscle testing may not be appropriate for individuals who have moderate to severe spasticity or rigidity, because the tone could essentially could interfere with how they are moving, and we can get a false reading, right? It's important to know that tone and even strength are influenced by positions, both body position and head position. And so it's important that, when you do assessment and reassessment, that you do it in similar positions, but also you're conscious about how the person is when you're doing manual muscle testing. Supine versus sitting at the edge of the bed. Sitting at the edge of the bed from a manual muscle testing standpoint would likely give you a better understanding of their muscle strength versus, of course, supine. It's important to understand that hypertonicity does not mean weak muscle. All right, so different classifications of upper extremity function, right? There is non-functional to an arm that can be used as a dependent stabilizer to independent stabilizer, gross assist, and so on. All right, so one of the things that people experience when they have hemiparesis or hemiplegia, whether it be due to stroke, which is, or brain injury, which essentially is affecting the upper motor neurons, right, or spinal cord injury, which certainly can affect or affects the upper motor neuron, or in the case of brachial plexus injury, peripheral nerve injury, right? There is something that's called subluxation. We've mentioned it a couple of times in previous lectures. Subluxation is a malalignment of the shoulder joint that's caused by instability at the glenohumeral joint, right? So, or the scapula. So essentially, subluxation is when there is a separation at the glenohumeral joint where there is a gap between the glenoid fossa and the head of the humerus, right? And there are three types of subluxations that can occur. The inferior subluxation, which is the head of the humerus, is below. It hangs below so if this is the glenoid fossa, this is the head of the humerus. Then what happens in the inferior subluxation is that the head of the humerus kind of starts to hang low, right? And anterior subluxation, which essentially means that the head of the humerus is popping forward. And then superior subluxation is that the head of the humerus is lodged under the acromion coracoid, so it goes up, right? Now, clinically, I believe the most common ones are inferior and anterior subluxations, and you can see them both occur at the same time. Now, what causes shorter subluxation? It is a combination of the weight of the arm, right? Gravity pulling the arm down, with scapular or instability of the muscles that act on the shoulder, or the weakness of the muscles that act on the shoulder that create instability in that area. And over time, what happens is that all the structures around there can stretch. The capsules, tendons, the ligaments can stretch. It could lead to rotator cuff tear or tear of some of those structures around that area. How do we measure subluxation? Clinically, the easiest way to measure would be to measure the distance from the acromion process to the head of the humerus, and you use your finger breadth. You can use a caliper, you can use tape. Most of the time we use our fingers and we describe it as 1 finger breadth or 2 finger breadth subluxation. Of course, x-rays can be done as well to document the extent of the subluxation, but the easiest way to do it is to use finger breadth method, as you can see in this picture. So 2 finger, likely 1 finger, might be even more. Now, so if you look at the picture on the right side of the screen, that person has an inferior subluxation, but you can also see the head of the humerus popping forward. So it's inferior and anterior subluxation, right? Right. Another thing to consider, right, with hemiparetic arm or an arm with hemiplegia is that dependent edema, right? And the reason dependent edema occurs is, one is because of positioning, right? The arm oftentimes hangs, in many cases, right, with or without hemiplegia or hemiparesis. Most of the times when we're walking, standing, the arm is hanging, right? Now, but the main thing is because of lack of muscular activity. And a lot of times fluid, or the way that fluid circulates, right, in our bodies, whether within the vascular system or lymphatic system, it is the contraction and relaxation of the muscles that push fluid. So anytime we're using our hands, our legs, the muscles are contracting, relaxing, so they kind of push fluid up, and they push blood in the in veins in an outward fashion where they as far as the blood is concerned, traveled back up to the heart. And so because with hemiparesis there's lack of muscle activity, fluids are not circulating, and because of the dependent nature of our arms, fluid then starts to accumulate distally into the hand. All right. This pooling of fluid essentially could create pressure on the extensor tendons, and it blocks any active or passive flexion, right? And it's important that we deal with edema. We are very diligent in dealing with edema because, again, if the edema accumulates, it can be painful, of course. It can also apply pressure on the extensor tendons and makes it difficult in terms of passively or actively bending the finger. And so then what could potentially lead to is stiff hands, right? Then even if the edema is reduced, if the extensor tendons are tight because of prolonged positioning in finger extension, then it's going to be difficult to regain passive flexion, even if there is movement. So we definitely need to do as much as possible to reduce edema as they develop. Apologies, I'm going to quickly plug my laptop so it doesn't die during this lecture. All right, I am back. Different ways that we can manage edema. Now, this is the glove that you see on the screen is called an isotoner glove or compression glove, and it's very effective. I use it a lot in the clinic. One thing that I typically like to do is cut the tips of the the tips of the glove so that the fingers are exposed. That way we can tell whether or not the glove is cutting circulation. So if the tips of the fingers start to discolor, I advise my patients to take them off immediately. Taping is another, kinesio taping, rock taping is another way in which that edema can be managed, and this is effective as well, and this is something that I utilize in the clinic. And there's different mechanisms of taping, but generally taping is something that certainly could be effective. As much as possible, retrograde massage is helpful as well. Positioning, right? So the arm should be positioned in an elevated fashion, especially when the person is sitting or when the person is lying down. Gentle, passive range of motion can be helpful in addition to retrograde massage. All right, handling of the hemiparetic arm. So there's different ways in which that different considerations from a handling perspective, right? Okay. Safe positioning. Slings are going to be very much important for hemiparetic arm. Now, the type of slings that are beneficial, and I've said it in a previous lecture, is not the typical kind of elbow sling that we see with people with orthopedic injuries. We do not want to promote prolonged positioning of the elbow and flexion, and because that could lead to increased tightness of the elbow flexors and maybe reduced length of the tendons of the elbow flexors, and we do not want that. So the type of slings that we want are either the Give More slings. The Give More sling, again, is the sling that actually initially gets anchored on the non-affected arm under the armpit, and there are two straps. One comes from the front, one comes from the back, and then the strap comes from the back, and then when it comes over to the weaker arm, one strap comes from the front, the other one from the back, and it gets anchored distally on the hemiparetic arm, and it provides that upward pull. There are actually studies that looked at its effectiveness in terms of increasing the glenohumeral articulation, and it does. However, of course, it's not going to lead to a correction of subluxation long term, but it does increase the glenohumeral articulation, and that's really what we want. The humeral cuff sling, or the proximal sling that I talked about, is also the one that wraps around the humerus with two straps. That one that comes from the back and one that comes from the front. That's also another good one that we utilize in the clinic. Lap trays, right? We call them half lap trays. These are very much important for wheelchair users. These are trays that get attached onto the wheelchair, and the arm is positioned on the tray. There is also something that's called a trough that gets attached on the wheelchair. The trough is another arm support that has lateral guards, and the arm sits in there. I prefer the lap trays because it frees the arm. The person has a slight movement. It frees the arm to move around a little bit. When it comes to positioning, we want to make sure that the arm is positioned in such a way that it is supported, it is elevated above the heart level, right? You can prop the arm up with a pillow to make sure that it is supported. And we want to make sure that the arm is not at risk of falling to the side of the bed, particularly if the person has limb awareness issues or proprioceptive issues. Whenever the person is positioning in the chair, they're, pillow support, regular chair that is, pillow support to elevate the arm. That's going to be very much important. We need to be very conscious of where a person's arm is during transfers, that it's not just flailing out to the side. And there are various techniques that you can use to support the arm. Splints are going to be important. Resting hand splint is one common one that is used for maintaining a functional range of motion of the hand in order to minimize the risk of shortening of the flexor tendons and loss of range of motion and eventually contractures. And there are various types of splints that are out there, but the most commonly used one in the clinic is a resting hand splint. All right, so the Give More sling, the sling that you see on the screen with the person that the black sling that the person is wearing, that's a Give More sling. This is a foam elevator, and this can be used whenever a person is the one next to the person with the sling. That's a foam elevator. Certainly used for positioning for edema management, prevention, or reduction of edema. This is the one on the other side is a wheelchair arm support. I'm not sure what happened there. All right. I think there might be a video associated with in this slide that I can't see, but then when I clicked, it took me to a web page. So I don't know. There you go. Okay, we'll skip that. You'll practice positioning within in the lab. Tone. All right. Tone is the resting state of the limb and the postural muscles. It's readiness essentially for activation, right? So a change in tone is a change in the resting state of the limb and in postural muscles. Now, when it comes to the skeletal muscles and tone, there are different types of abnormalities that we can observe, right? Flaccidity is the complete absence of muscle tone, right? And the deep tendon reflexes are not there, and active movement is not there. Hypotonicity is low tone. There's little or no muscle activity available at that particular stage. Deep tendon reflexes may be diminished or may be absent. Hypertonicity is increased tone, right? Increased activation, not voluntary, of course. Right. So now this hypertonicity can occur in synergy patterns, flexor synergy and extensor synergy, right? In flexor synergy, there's something that's called decorticate posturing. And that's oftentimes you see with early stages of traumatic brain injury. It's flexion of the upper extremities and then rigid extension of the lower extremities. Whereas in extensor synergy, you have something that's called decerebrate posturing, which is the extension, rigid extension of all limbs and neck. Again, posturing could occur, this type of posturing could occur after severe TBI or anoxic brain injuries. Anoxic brain injury is a brain injury due to lack of oxygen to the brain. All right, so give that one. Spasticity is oftentimes seen in muscles that are hypertonic. And spasticity is increased muscle involuntary muscle activity dependent on velocity. So it's velocity dependent. Could hyperactive stretch reflex. It could be something that's called clonus, different stereotypic posturing and things like that. Now, when clonus is a condition where with certain change in limb position, you would notice this rapid, uncontrolled movement of that limb. Oftentimes, with pressure, it stops. All right, and by hyperactive stretch reflex is that when you stretch the arm in one direction and you stretch the muscle that would essentially when you do it, for instance, or when you stretch the elbow in extension, right? You're stretching the elbow flexors, and with that stretch, the elbow flexors start to activate involuntarily, and they become hyperactive essentially. And that's how you assess spasticity. Actually, it's quick movement, stretching the muscles that you're testing, and because it's velocity dependent, what you're measuring is how much involuntary activation is noticed in the muscle that is being stretched. So you quickly stretch the muscle, and you see how it responds. And the test that is oftentimes used in the clinic to assess spasticity, again, which is hyperactivity of the muscle, velocity dependent, is the modified Ashworth. And we'll get a chance to practice that in class. All right. Okay. So I think we won't go through these videos, but we will likely practice them in class. All right, spasticity, the modified Ashworth. It's a 5-point scale, right? So essentially, when you do that quick stretch of the muscle, for instance, like I use the bicep as an example, right? If I quickly stretch an extension, I'm trying to see what the muscle, the elbow flexor's response is, right? If there's no catch, then the scale is, or the score is 0. There's no increase in muscle tone. If there is a slight increase in muscle tone, meaning that if there is a catch and release at the end range, so like I stretch it, at the end range there's a catch and then release, that's a 1, right? If there's a catch and release, minimal catch and release throughout the 1/2 of the range of motion, not the end range, but 1/2 of the range of motion, that's 1+. If there is increased muscle tone through most of, or catch and more marked increase, catch and harder release through most of the range of motion, then it's 2. If it requires a lot to move the arm through the range of motion, then it's 3. If the arm cannot move through the plane or through the then it would, if it's rigid stuck essentially, then it's 4. All right, you can watch the video at your leisure. All right, so modified Ashworth practice, we'll do that in class. Primitive reflexes. Now, these when if you remember back from prior classes about development, as babies develop, of course, from birth through their early toddler days, they go through certain primitive reflexes, right? And so a lot of these primitive reflexes become, or all of them, they become integrated and they integrated, I should say, into controllable movement patterns, right? So with brain injuries, then these primitive reflexes can become dominant again, and they can interfere with moving, right? Rolling, functional mobility, ADLs. They can, because they become predominant, and they can certainly impact volitional movement patterns. Certainly, that could impact different kind of ADL engagements. These are the different primitive reflexes. I won't go through them. All right. Okay, so we will likely do reflex testing. We will do reflex testing in lab. Okay, how do we assess? So another thing that gets impacted with any type of neurological condition, more particularly stroke, brain injury, spinal cord injury, is posture and trunk control, right? How do we assess trunk control? Well, first we got to make sure that the person's feet are flat on the floor, right? You want to set up the person and you want to set up the environment in a way that, of course, makes it safe for the person, and you have good access to a good view of the person's trunk. And so it's going to be very difficult to do a postural assessment if the person is sitting in a tilted space wheelchair, right? So oftentimes when I do trunk control assessment, I do have the person sitting at the edge of the mat. If there is support needed, I'll bring in a tech or someone that can assist, right? Now, what are some of the things that we want to look at? Is the person able to maintain sitting balance? That's the first step of it, right? With feet flat on the floor, right? Good base of support, and making sure that the person is sitting deeper in the mat, right? They're not really sitting at the edge of the mat. I like to make sure that at least the person has 3/4 of their thigh supported on the mat or whatever area that they're sitting on, and I evaluate to see if the person has ability to maintain an upright posture, or do they fall. When they fall, do they have righting reaction, meaning that do they direct their head to an upright posture? Do they have equilibrium reactions? Are they able to sustain or keep a position? Protective reactions, right? When they fall, do they extend their arms and hands if they have movement capabilities to be able to support themselves, right? Now, so all of those things are things that we're going to look at, right? Are they able to maintain their balance? If they fall, do they have righting reactions, equilibrium reactions, and protective reactions? How is their pelvis positioned when they're sitting? Is it a neutral position? Is one pelvis elevated or pelvic bone elevated than the other? Is one rotated forward than the other? So we're looking at symmetries, right? Are they bent over like this, or are there what we call in anterior or posterior pelvic tilt? Are they slouching in their lumbar spine, or is their lumbar spine hyperextended? So different things to look at, right? Are they demonstrating something that's called the Cushing syndrome? And the Cushing syndrome, if you're all not familiar with this, is a condition where the person not just falls over to the weaker side, but they're pushing themselves over to the weaker side. So there are certain, and this is a perceptual thing. What I mean by perceptual is that the person's internal representation of their midline is skewed such that they think they are a midline when they're leaned over slightly or extensively towards the weaker side. And there are some kind of classic, of course, presentations of Cushing syndrome, one of which is leaning over to one side. The second part is extension of the unaffected arm, or abduction, extension and abduction of the unaffected arm, or abduction of the unaffected lower extremity, where they push with that towards the weaker side. Um, People with pushing syndrome, controversive pushing is what it's called. You can't just push them to midline. They're going to resist you. That's not something that can be that is advised. You can't tell them sit in the middle because that is their middle. You have to use external feedback, mirror in front to allow them to see where they are, so that they're usually utilizing visual information for postural correction. Working on getting them to reach towards targets on the right, on the unaffected side, so that they're actively engaging their trunk and reaching towards the unaffected side. Many times I have people sit next to a wall on the mat on the unaffected side, so that tactile information on the unaffected side is letting them know where they are in space. So there's various ways that you can address that using external cues. It's important to look at, how other systems uh, contribute positively or negatively when it comes to posture. Um, Vision. Are there visual impairments? Is there inattention? Oftentimes, controversive pushing and inattention go hand in hand. What is their cognitive capabilities? That all can impact posture as well. Um, Posture is very much important for upper extremity control. For instance, if I am slouched over like this, right? So I have like this kyphosis posture, meaning bent thoracic vertebrae, right? It's going to be very difficult, and then of course that can lead to protraction of my scapula. My shoulders are coming forward, so this is going to be very difficult. This is as far as I can take my arm, so it's going to be very difficult for me to reach up with this posture. But if you open up the chest cavity, get into this thoracic extension, then I can bring my arm a lot higher. So posture impacts upper extremity control. So before you engage a person in any type of sitting level, functional use of a hemiparetic arm or range of motion type of exercises, you need to make sure that their posture is appropriate. All right. So trunk control is ability to maintain your upright posture. One thing that you should not do is that if the person cannot independently sit up without support, without uh, upper extremity support, if they have trunk control issues, postural issues, what is it that we look at? Yeah, postural issues. Never leave a person unattended at the edge of the mat. Even if they do have postural, if they can control their trunk or have good trunk control, um, uh, if the person has cognitive impairments, inattention, visual issues, never leave a person unattended. Make sure that if you need to go get something, that you have somebody who is there to keep an eye on the person, provide support, who is trained and able to do so, or ask somebody else to get it for you. I mean, this is highly important. Never leave anybody who doesn't have adequate trunk control sitting at the edge of the mat, unsupported, edge of the bed, unattended. All right. Okay. So when to assess trunk control, right? Trunk flexors, trunk extensors, lateral flexors, trunk rotation, all of these certainly need to be evaluated to make sure that a person has good trunk control. Pusher syndrome, we talked about that. It's a perceptual issue, it's a sensory processing issue, and certainly has motor control involvement and cognitive function as well. Yeah, we talked extensively about what it is and how to essentially deal with that. Um, I may have jumped the gun. So from a treatment standpoint, of course, visual feedback, mirror, right? Giving reference points, uh, like the wall on the unaffected side, right? Um, and then reaching towards the targets on the unaffected side to work on that independent postural correction. Um, Definitely people with controversive pushing are at a higher risk of falls, obviously. And so I think that focusing on maximizing their safety is important. Or if they are in the wheelchair, they might need specialized backs, right? Because they are leaning too much on. Um, it could be leaning too much on the one side. And if they're sitting in the regular chair, the armrest of the chair may be pressing up against their trunk or the lateral trunk area. And that could cause skin breakdown. So it's important to also address positioning within the wheelchair and consider different type of adaptations, from the type of wheelchair and the back support standpoint. All right. Okay, so and I think we're going to talk more about this, but what we see here is this person. If you look at the person from the back, they do have what seems like flexed the hyperflexion of the lateral trunk or the trunk on the left side, right? So so they're kind of bent on the right side and overstretched, on the left side and overstretched on the right side. So they may have a pelvic obliquity as well. The left pelvic bone may be slightly elevated compared to the right side. Other things we can notice here is that the shoulder is lower than the left. You don't have a clear access to their scapula, and so there might be some asymmetry of the scapula, of course, right? Maybe a little bit of depression, scapular depression. Okay. All right, kind of similar presentation. Hiked shoulder here, slightly leaned over to the right side. Still a little bit of lateral flexion here, elongation on the right. All right, let's see what these videos are. We might just, oh yeah, this is the ICE learning. Apologies, some of these are not coming up really well. All right, so I think these are some videos we likely will watch in class, or if you have time, of course, I would advise that you watch some of these videos. Interventions, and now these interventions are for motor recovery, or for hemiparetic arm. Splinting is certainly an intervention that is often used in therapy to prevent muscle joint contracture or loss of range of motion. And then if a loss of range of motion does occur, we certainly could work on splinting to try to increase range of motion. Taping is used for various reasons. Tapings could be used for managing subluxation, shoulder subluxation. So there are a couple of different types of taping that are out there. I use something that's called California tripole technique. So that's helpful. There's evidence behind it. Guided imagery. So let's go back to taping. So kinesio taping is more flexible. Rigid taping like Leuco taping or McConnell are very rigid. Rigid taping are good for stabilization. K-tape, kinesio taping is used for facilitating movement and reducing edema. Guided imagery, mental practice, these are ways in which that we could help with motor recovery, but as adjunct interventions, right? And they also can be used for as a home exercise programs. Mirror box therapy is it's what's called mirror therapy, and oftentimes it is used for desensitization purposes if the person is experiencing hypersensitivity. And I won't go in detail about it, but certainly if you're not familiar with it, you can search it, and there's specific kind of protocols and ways that you can apply this particular strategy. Robotics are heavily used, and both for in many cases for promoting motor recovery, but also for allowing for the limb to be used functionally, right? Virtual reality, immersive, semi-immersive, augmentative virtual reality systems that are used for motor recovery. The studies are, show some efficacy, but not superior to the task-oriented approach. However, they could be definitely beneficial as adjunct therapies, and a lot of times they promote engagement because they're engaging And so it promotes engagement among patients. Physical agent modalities, different type of modalities out there. NMES, neuromuscular electrical stimulation, is for motor recovery. TENS unit for pain management. Um, you know, other modalities include diathermy for pain, ultrasound for pain, with limited evidence, of course. So there are different type of physical agent modalities. Most commonly used, at least in my practice, are neuromuscular electrical stimulations. These are the different type of splints for positioning or functional splints. The resting hand splint, the big one that you see is a resting hand splint. The one below it is called a thumb opponent splint. It allows for the thumb, it immobilizes the thumb, of course, if in a case of pain, but also, well, actually, no, I lied. That's a thumb spica splint for immobilization. There's a similar splint called thumb opponent that brings the thumb inward, and when people have difficult ability to oppose their thumb, you can position the thumb in that way so that they're able to manipulate things with their hands. This is wrist cock-up splint. The one that you see at the top right corner is a dorsal wrist support, and oftentimes used with people who have wrist drop and spinal cord injury, peripheral nerve injuries. And you can also use it as an adaptive tool for self-feeding and other kind of ADLs. The one that you see on the bottom right corner is dynamic splint, complex to make, never made one. Oftentimes used for increasing range of motion post-leg injuries or hand surgery and things like that. All right, so some tools, right? So this is taping, shoulder taping, either kinesio tape or rock tape. These are elbow braces. Oh yeah, so the one picture that you see with the guy with the mirror, that's mirror therapy. Essentially what he's doing is what seems like he's doing, and that's how mirror therapy is practiced, is that you hide the affected limb behind the mirror, and then the unaffected limb is going to move, and the person is going to look at the reflection of the unaffected limb moving, and essentially to kind of give the brain the perception that the affected limb is moving by looking at the mirror, and that kind of increases cortical activation and potentially cortical reorganization. All right, so this seems like I cannot tell what this is. It seems like a glove that has a spring system that allows the finger to move. There are different type of gloves like that, and of course this is an MES application, electrostimulation. All right, so when choosing interventions, choose wisely, right? Never use interventions that are not purposeful or engaging, right? Cones, pegs, shoulder arc, arm bike. There may be place for cones and pegs and arm bike, but in many cases these are not purposeful, these are not engaging. So really use activities that are relevant and salient for the individual. All right. When you use physical agent modalities, make sure that you use them as a functional electrical stimulation, meaning that as augmenting movement so that the person can engage in purposeful tasks during the session, right? Not just slap the e-stim on and just, leave the person for 15 minutes. Make sure that the person is engaging in something productive or something purposeful and salient while the e-stim is being applied to stimulate a specific muscle group. Right. Do not use pulleys. That's it. No need to elaborate there for people with hemiplegic shoulders, of course. Now, for some orthopedic injuries, pulleys may be beneficial. For instance, frozen shoulder with person specifically with frozen shoulder, not a hemiplegic shoulder that also has a frozen shoulder. But specifically with frozen shoulder, pulleys may be beneficial. And as I said multiple times, right, do not use the sling, a sling that places the arm in a elbow flexion pattern, right? Again, extended positioning of the elbow in that way or in that position can lead to shortening of the elbow flexors and the elbow flexor tendons. All right. Okay, I think this is it from a lecture standpoint. If you have any questions, concerns, if something that we went over today does not make sense, or if you would like for us to elaborate on, please send us an email both to myself and Dr. Glover, or bring it to class. We're certainly more than happy to clarify anything. But we'll also get the opportunity to get hands-on in lab. So I look forward to that. All right. You all have a great week.